Psychiatry is a branch of medicine that deals with mental, emotional, or behavioral disorders. The term psychiatry was first coined by the German physician Johann Christian Ryle in 1808 and literally means the medical treatment of the soul from ancient Greek psyche. A medical doctor specializing in psychiatry is a psychiatrist. Psychiatry treats mental disorders, which are divided into three general categories: mental illnesses, severe learning disabilities, and personality disorders. Treatment may include psychotropics, psychotherapy, substance abuse treatment, and other modalities such as interventional approaches, confinements, assertive community treatment, community reinforcement, and supported employment. We will mainly focus on the treatment with psychotropics and interventional approaches. If you're sick, you seek treatment. To heal yourself, that's something we can agree on. But why are people revolting against psychiatry worldwide? Why wouldn't you want to be admitted in a psychiatric hospital? Because it's a tool of abuse, overreach, and control. One of the most glaring historical abuses of psychiatry lies in the institutionalization of individuals, not for mental illness, but for their perceived deviation from social norms. Asylums, particularly from the 18th to the mid-20th centuries, were often used less as spaces for healing and more as instruments of exclusion and control. Women were especially vulnerable. The diagnosis of hysteria became a catch-all label for female behavior that defied patriarchal expectations. Women who displayed sexual independence, resisted domestic roles, expressed strong emotions, or even simply challenged male authority could be institutionalized indefinitely. In many cases, this confinement had less to do with mental illness than with enforcing obedience and conformity. Beyond gender, psychiatric institutions were also weaponized against political dissidents. In authoritarian regimes, psychiatry was sometimes co-opted by the state to silence opponents. The Soviet Union stands as a notorious example where dissent against the government was pathologized. Individuals who questioned the Communist Party could be diagnosed with so-called sluggish schizophrenia, a condition allegedly marked by minimal outward symptoms, but an internal opposition to authority. Once labeled, these individuals were forcibly committed, medicated, and removed from public life, effectively neutralizing political resistance under the guise of medical necessity. Similarly, LGBTQ+ individuals were long treated as mentally ill by the psychiatric establishment. Until the late 20th century, homosexuality was classified as a disorder in diagnostic manuals such as the DSM, Diagnostic and Statistical Manual of Mental Disorders. This classification justified a wide range of so-called treatments, including electroconvulsive therapy, chemical castration, aversion therapy, and institutionalization. These interventions caused deep psychological trauma and were often administered without consent or recourse. Rather than being spaces of care, psychiatric institutions became sites of punishment for those whose identities or beliefs diverged from what was deemed socially acceptable. This dark chapter of psychiatric history reveals how mental health systems have, at times, served as tools of moral judgment, political repression, and cultural enforcement. Instead of addressing genuine psychological suffering, psychiatry was frequently used to pathologize difference and suppress dissent. The use of asylums to marginalize women, political activists, and LGBTQ+ individuals reflects the dangerous potential of medical authority when it aligns with oppressive social norms. Understanding these abuses is essential, not only for acknowledging past wrongs, but for safeguarding human rights within mental health systems today. In Nazi Germany, psychiatry played a chilling and integral role in one of the darkest chapters of modern history. The systematic extermination of individuals deemed unfit to live. Under the ideological framework of racial hygiene and eugenics, Adolf Hitler's regime sought to purify the German population by eliminating those considered biologically inferior or burdensome to society. Psychiatric institutions became a key apparatus in this vision. Long before the mass extermination of Jews, Roma, and others in concentration camps, the Nazis initiated what is now known as the T4 program, a state-sponsored euthanasia initiative targeting people with mental illnesses, intellectual disabilities, and other conditions regarded as hereditary defects. Between 1939 and 1945, an estimated 200,000 to 300,000 psychiatric patients were murdered under this program. Doctors and psychiatrists collaborated with state authorities to identify individuals for disinfection or mercy killing. These victims were often patients in psychiatric hospitals who had no say in their fate and whose families were frequently deceived about the causes of their deaths. The killings were carried out in gas chambers disguised as showers, a technique later scaled up in the Holocaust. In many ways, the T4 program served as a blueprint for the industrialized mass murder that would come later, both in methodology and in moral justification. What makes this chapter particularly disturbing is that it was executed not in secret, but with the full cooperation of trained medical professionals. Psychiatrists, instead of acting as protectors of the vulnerable, became agents of state violence. They developed pseudo-scientific criteria to assess life unworthy of life, reinforcing Nazi ideology with a thin veneer of medical legitimacy. The psychiatric community, far from resisting, often led the charge. Many willingly participated in sterilization programs, endorsed euthanasia, and facilitated the extermination process under the guise of public health and economic efficiency. This period reveals how psychiatric knowledge, when combined with totalitarian ideology and stripped of ethical accountability, can become a deadly instrument of oppression. It is a stark reminder that science and medicine are not inherently benevolent. They are shaped by the values and power structures of their time. In post-war Germany, many of the doctors who had participated in the killings were never held accountable. Some returned to medical practice. Others quietly disappeared into post-war society. The full reckoning with psychiatry's role in Nazi crimes took decades to emerge. Studying the complicity of psychiatric institutions in the Nazi regime is not merely an exercise in historical memory, it is a warning. It reminds us of the importance of ethics in medicine, the need for strong safeguards against state overreach, and the devastating consequences when medical authority is used to justify violence and dehumanization. Early electroshock therapy, also known as electroconvulsive therapy, or ECT, emerged in the 1930s as a treatment for severe mental illnesses such as schizophrenia and depression. At the time, little was understood about its effects, and the procedure was often administered without patient consent. Many patients were subjected to ECT against their will, sometimes multiple times a day. The treatment caused intense physical side effects, including memory loss, broken bones, and seizures. It was often used not just therapeutically, but as a form of control or punishment within psychiatric institutions. In some cases, it was applied to calm, agitated patients, or discipline those deemed non-compliant. Consent protocols were minimal or non-existent, especially for women, minorities, and institutionalized individuals. Rather than a healing tool, ECT became associated with fear and trauma for many. Only in later decades did medical ethics evolve to demand informed consent and stricter regulation of its use. Lobotomies were introduced in the 1930s as a supposed cure for severe mental illness, but quickly became a tool to manage behavior rather than treat underlying conditions. The procedure involved severing connections in the brain's prefrontal cortex, often resulting in drastic personality changes, cognitive decline, or emotional blunting. It was used on patients deemed unmanageable or difficult, including women, children, and nonviolent individuals. Many lobotomies were performed without proper consent or understanding of the risks. In the U.S., thousands were operated on, often in overcrowded institutions seeking quick fixes. Dr. Walter Freeman popularized the transorbital lobotomy, which could be done in minutes using an ice pick-like instrument. The results were often tragic. Patients lost their autonomy, identity, and ability to function. Instead of healing, the procedure silenced. Lobotomies are now viewed as one of psychiatry's most shameful chapters. Their legacy highlights the dangers of reducing complex suffering to crude interventions. For much of the 20th century, individuals could be confined to psychiatric wards without proper legal procedures or oversight. Families, spouses, or authorities could institutionalize someone with little more than a signature. Once admitted, patients often lost basic rights, including the ability to contest their confinement. Many were held for indefinite periods, regardless of whether they posed a real danger to themselves or others. Women, the elderly, and marginalized groups were especially vulnerable to unjust internment. In some countries, political dissidents were labeled mentally ill to legitimize their detention. Inside institutions, conditions were often harsh, with little accountability. Patients had limited access to legal representation or external review. The absence of due process turned psychiatric wards into hidden prisons. This history underscores the need for strong legal protections in mental health systems today.
In modern psychiatry, there has been growing concern over the pathologization of normal human emotions. Feelings like sadness, anxiety, grief, or fear, once seen as natural responses to life events, are increasingly labeled as symptoms of mental disorders. For example, intense grief after the death of a loved one may be diagnosed as major depressive disorder after just 2 weeks. This trend risks turning everyday struggles into medical conditions. As diagnostic manuals like the DSM expand, more people fall under psychiatric labels. The result is often unnecessary medication and a diminished tolerance for emotional discomfort. Rather than addressing root causes like social stress or trauma, symptoms are medicalized. Pharmaceutical companies have played a role in promoting this shift. Pathologizing normal emotions can erode resilience and personal agency. Mental health care must distinguish between suffering that needs support and emotions that are simply human. In recent decades, there has been an exponential rise in psychiatric diagnoses worldwide. Conditions like ADHD, depression, anxiety, and bipolar disorder are now diagnosed at rates far higher than in previous generations. While greater awareness plays a role, many experts warn that diagnostic thresholds have been lowered. Behaviors once considered within the range of normal, such as restlessness in children or mood swings in adults, are increasingly medicalized. Schools and workplaces often push for labels to justify support or discipline. This surge in diagnosis has fueled massive growth in prescription drug use, especially among youth. Some patients benefit, but others are misdiagnosed or overtreated. The expanding criteria in manuals like the DSM blur the line between illness and personality. Overdiagnosis can lead to stigma, dependency, and unnecessary medicalization. A more cautious, holistic approach is urgently needed. Pharmaceutical companies have played a major role in expanding psychiatric diagnoses by aggressively marketing mental illnesses to promote drug sales. Conditions like depression and anxiety were heavily publicized alongside campaigns for SSRIs, creating demand for quick pharmaceutical fixes. Benzodiazepines, initially marketed as safe tranquilizers, led to widespread dependency and withdrawal crises. ADHD medications have been increasingly prescribed to children, sometimes after minimal evaluation. Marketing often targets doctors and the public simultaneously, blurring education with promotion. Diagnostic inflation helps expand the customer base for these drugs. In some cases, pharmaceutical firms have funded studies, influenced guidelines, and minimized side effects. The result is a global surge in psychotropic drug use, sometimes without clear long-term benefit. While medications can help many, profit motives have distorted psychiatric care. The medicalization of distress has become a lucrative business model. Western psychiatric models have increasingly been exported to the global South, often disregarding local cultural and spiritual understandings of mental suffering. Traditional healing practices, rituals, and community-based approaches are sidelined in favor of standardized diagnoses and medications. In many cases, spiritual experiences, such as hearing ancestral voices or entering trance states, are pathologized as symptoms of psychosis. This undermines cultural identity and imposes a narrow Western view of the mind. Even for those who don't believe in spirituality, it's essential to respect others' freedom to interpret their experiences in their own way. Imposing foreign models can erase valuable indigenous knowledge systems. Global mental health campaigns sometimes equate Western psychiatry with progress, ignoring local context. The result can be dependency on pharmaceuticals and erosion of cultural autonomy. True mental health care should be inclusive, not colonial. Respect for diverse worldviews is not optional, it's ethical. The World Health Organization has criticized the over-reliance on medication in many global mental health programs, warning that drugs alone cannot address complex social and psychological needs. They emphasize the importance of community-based care, psychosocial support, and culturally sensitive approaches. Over-medication risks neglecting root causes like poverty, trauma, and discrimination. WHO advocates for balanced strategies that combine medication with holistic interventions. This ensures more effective and humane mental health care worldwide. The troubling history of psychiatry, from asylums used to silence marginalized groups to the horrific abuses under Nazi Germany, still echoes loudly in the present day. Although modern psychiatry often presents itself as a compassionate science, the legacy of coercion, overdiagnosis, and profit-driven treatment reminds us that it is not always a friend to those it claims to help. The pathologization of normal emotions, the exponential growth in diagnoses, and the widespread reliance on powerful medications reveal ongoing patterns of control and medicalization rather than genuine healing. Psychiatry's influence continues to shape how society defines normal and madness, often at the cost of individual freedom and dignity. The exportation of Western models and the dominance of pharmaceutical interests further deepen these issues on a global scale. To truly support mental health, we must challenge the assumption that psychiatry is an infallible ally. Instead, we need approaches rooted in respect, human rights, and cultural diversity, ones that empower rather than suppress. Only by confronting psychiatry's past and present excesses can we hope to build a more just and humane future for mental health care. Psychiatry, as it stands, is not on your side. Awareness is the first step toward reclaiming autonomy and redefining what healing really means.